Dear chairs, dear audience, let me introduce my PhD thesis, which is Daily Aspects of Oral Medicine. My name is Bálint Zsombor Sárai, a second-year PhD student and a periodontology resident in the Department of Public Dental Health. My supervisor is Orsolya Német, my SMS is Bianca Golzio. My mission is to make a positive difference in all patients' life. My vision is to achieve affordable and good oral health for everyone. To achieve this, I have two specific goals, from which the first is investigating the efficacy of different treatment methods in Oral Lichen Planus through a systematic review and a network meta-analysis. Regarding the pathogenesis, Oral Lichen Planus is a chronic inflammatory disease of the oral mucosa. Because of the sensitivity, patients at first avoid spicy food. Later, they can only eat neutral taste food and can drink only warm water. The striae cause tension in the mucosa, which makes constant discomfort. The disease is not life-threatening, but it reduces the patient's quality of life for decades. Over time, social anxiety and depression can also develop. Speaking of its treatment, there is no gold standard. Topical steroids are used in the first line, however, these have numerous systematic and topical side effects. Recently, calcineurin inhibitors, which reduce the concentration of pro-inflammatory cytokines, also take place. Based on that, our aim is to compare the most frequent treatments to get the most effective result. Our question is, which is the more effective treatment, topical steroids or calcineurin inhibitors in patients suffering from Oral Lichen Planus? Based on the PICO framework, we have a population with OLP. We are comparing calcineurin inhibitors, steroids, and placebo to each other to get the outcomes of lesion morphology, severity of pain, and adverse effects to investigate the safety. Our hypothesis is that topical calcineurin inhibitor treatment has better efficiency and longer effective period than measured in topical steroid therapy for OLP. Our systematic search was conducted in 2023, and it was redone in 2025 with the search key mentioned on the slide in 4 different databases. After the selection process, we got 28 eligible articles for the qualitative and quantitative analysis. We have 3 main outcomes: severity of pain using the visual analog scale, lesion morphology using the clinical scoring system according to Tong, Prasam, and colleagues, and a type of adverse effect, transient burning. Recent analysis focused on the severity of pain using the visual analog scale. Pain is measured on a 10-centimeter long scale by the report of the patient. A total of 5 studies were selected in the analysis with 3 kinds of treatments and data on 275 subjects. According to Sucraplot, based on our analysis, calcineurin inhibitor therapy was the most effective treatment, followed by steroid therapy, and placebo had the least impact on decreasing pain in analyzed subjects. A closer look at the league heat plot shows us that calcineurin inhibitor therapy was the best choice, as the pain decreased 0.11 more compared to steroids and 1.32 more compared to placebo. However, we couldn't find any statistical significance. To step to the pairwise meta-analysis part, we were comparing calcineurin inhibitors to steroids with 137 and 139 subjects in each group. The effect of measure was mean difference after 4 weeks of treatment. As you can see, we couldn't find any statistical significance or clinical relevance in mean differences between these 2 therapy regimens. Our next outcome is lesion morphology. A total of 3 articles were selected, which described the lesion morphology on a scale from 0 to 5, according to Tong, Prasam, and colleagues. We were comparing calcineurin inhibitors to steroids with 79 subjects in both groups. The effect of measure was mean difference after 4 weeks of treatment with 95% confidence intervals. As you can see, we couldn't find any significant difference between the 2 treatments. Our last analysis focused on transient burning. Transient burning occurs during the last 2 days of treatment period after the drug application. Also, we were comparing calcineurin inhibitors to steroids with 121 and 126 subjects in the groups. As you can see, we couldn't find any statistical significance. However, transient burning occurred 2.5 times more in the calcineurin inhibitor group, so we can say that it's clinically relevant difference. Our strengths are that this is the first network meta-analysis. In this topic, we included only randomized controlled trials, and there are direct and indirect comparisons between the treatment possibilities. Our limitations are that we have a small sample size from a heterogeneous population, and there are different treatment periods grouped together. Based on our findings, we can conclude that calcineurin inhibitors are equally efficient as steroids, however, have more side effects during the first 2 days of treatment period. For the research part, there is a need for universal scoring system regarding mucosal morphology, and there is a need for longer follow-up periods and the detailed side effect reports. Our manuscript has been submitted for the third time, the JDR Clinical and Translational Research. Now we are waiting for their response. Sorry. My second topic is investigating the efficacy and safety of laser therapy on oral mucosal lesions through a systematic review and a meta-analysis. Oral mucosal lesions can be complications of radio or chemotherapy or can have autoimmune origin. These lesions start to develop in an asymptomatic manner, followed by the presence of erythema, burning, and increased sensitivity. Erythema may progress into desquamation, followed by the appearance of ulcers associated with dysphagia. Because of its complexity, there is no standard treatment. Topical and systematic therapies include avoiding certain foods, the use of steroids or anti-inflammatory therapies. Luckily, there is a newer approach that uses laser to prevent and heal these lesions. That's why our aim is to help people with recurrent pain to live a quality life. Our question is, how efficient is laser therapy compared to conventional therapy on oral mucosal lesions? We are comparing laser therapy to conventional treatments in a population with oral mucosal lesions to get the outcomes of healing time and severity of pain. Our hypothesis is that laser therapy has better efficiency, less harmful effect, and promotes healing better than conventional treatments on oral mucosal lesions. The systematic search was conducted in 2024 with the search key mentioned on the slide in 3 databases. After the selection process, we got 66 eligible articles for the qualitative and quantitative analysis. We finished the data extraction part. Now we are working on the risk of bias assessment, and I've started to write the manuscript with the methods part. To mention my aims, my first topic is submitted, and I plan to submit my second topic during the summer of 2025. Let me end my presentation with my additional activities. Success is an achievement and not a final destination. Thank you for your attention.
You mentioned this later part I missed, or I was expecting to say to hear about the results a little bit of the laser treatment, but you have no clue yet. No strong evidence, so yes. But the direction is there, or what you expect, or even that is not very clear?
It's not ready. It's not ready yet.
Okay. The question would be that what type of laser was used as far as wavelengths, and also how many times and how many, can you standardize this? Because I expect quite a wide range.
Thank you for your question. There is a specific interval of wavelengths from 660 to 900 nanometers for the soft lasers, for the low-level laser therapy. And I think we can't standardize it because there are different cycles of use these treatments, and in studies they used the laser up to healing. So someone has got 3 cycles, someone maybe 5 or 6, and in different time points. So someone was going every day for the treatment, or in other studies they used once in every week.
Okay. And any additional material were used during their laser therapy, like methylene blue or something else, which
No,
is
no.
okay.
And just joining this topic, what was the comparator, the conventional treatment? Because that could probably be a big difference.
Thank you for your question. In most of the cases, there were steroids used, topical steroids.
And how many articles did you find for this second topic?
66 eligible, but we don't have enough data, so maybe 10 or 15. Yes.
All right. And for the first topic, I would like to ask, were you able to assess and somehow maybe subgroup on what anamnestic factors the patient had who developed this oral lichen planus? Because that could probably affect the healing and not only the medication, the treatment.
Thank you for your question. They didn't describe these factors. They were inclusion and exclusion criteria just described, and based on that we grouped together
so
patients
you had specific exclusion criteria that you could at least consider.
Yes.
Mm-hmm. And how long were these oral lichen planus present before they started giving the treatment? Or could there be patients who had steroid treatment unsuccessful and then they tried the other treatment possibly?
So an oral lichen planus patient has symptomatic and asymptomatic periods. And these trials were conducted during the symptomatic period of the lesion. And if someone got medication and treatment before the treatment period, the trial period, then had to conduct a washout period of 3 months. So maybe 3 months of symptomatic.
With your first study with oral lichen planus, just correct me if I'm wrong, but there are positive and negative consequences with both of the treatments. Yes?
Yes.
Good. I've got it right. Okay. So, am I right in saying that the main adverse effect for the calcineurin inhibitor is the transient burning?
Thank you for your question. Not the main, but the main that was reported
Right.
in the articles.
So what's the main adverse effect?
It wasn't mentioned in the articles. So it was mentioned in most cases that no serious adverse effects occurred during the trial period. Someone is expecting a possible malignization after the use these calcineurin inhibitors, and that's why we need some more evidence, some long follow-up periods to ensure to be safe.
Right. And from your findings in that study, if a patient presents with oral lichen planus, how are you going to manage her or him?
So at first, we have to maintain their oral health, their oral hygiene, and we have to maintain their risk factors, like stress or bed prosthesis, etc. And after that, if the patient has an active flare-up, then we can start a treatment.
Which is?
Now, which is steroids.
Yeah. And then when would you consider the calcineurin inhibitors?
Thank you for your question. In case of steroids, there might be a drug tolerance development, and in the case of no response, we can progress into use of calcineurin inhibitors.
Right. So, and just in the pain area, we often use, because of adverse events from multiple medications, we'll use polypharmacy. So we'll try to lower the dose of the medications by adding 2 medications. Is there any benefit, do you think, in considering using a topical steroid with the calcineurin inhibitors?
I think there is. Thank you for your question, but there is no evidence yet about the use of both drugs in the same time.